My name's Indra. I'm one of the radiology trainees based in Oxford. I'm just going to spend the next kind of 45, 50 minutes talking about fibroid embolisation. In terms of the aims of the session, I think I wanted to have a bit of clinical background just so we know kind of the presentation and how fibroids present. We'll go through some of the imaging modalities that are commonly used. We'll go through some of the management options, not just embolisation, but some of the surgical options as well. And then we'll go on to talk about embolisation and briefly touch upon some other IR interventions for women's health, although that's not really the main focus of the talk, but they do sometimes come up in med school exams and stuff as well. So an introduction to fibroids. So essentially, fibroids are benign tumours of the myometrium. So the innermost layer is the endometrium, the muscle layer is the myo, and then outside you've got the serosa. And the reason that's important is I put this diagram here to show that the pathogenesis is pretty much the same as how cancers grow. So the native cell has mutations and has unregulated growth. But the difference is it's not a malignant tumor, it's a benign tumor, so it won't spread outside the location that it's grown. So as with cancers, there's some kind of genetic factors and there's also some environmental factors. And some of those interactions will result in abnormal growth, dysplasia, and eventually a mass, which will be a fibroid. And the difficulty in estimating the prevalence is that lots of these patients are asymptomatic. And so lots of patients will actually have fibroids and we won't know about them, which is why there's a huge variation in the literature in how prevalent the condition is. So depending on the population and which imaging methods they use, that varies between about 5% all the way up to 70%. And the main problem with it is quality of life problems. So in the USA alone, it costs $34 billion a year, half of which is from lost productivity because of symptoms. So in terms of treatments, it's all to do with quality of life treatment, which is important to kind of mention because those will be the main outcome measures for which we measure the success of treatment. And in terms of risk factors, again, there's lots of different ones that are quoted, but the most consistent one is having a black race. So Black women are 2 to 3 times more likely to get fibroids, and not only get them, but they're more likely to present with them at a younger age, and they're more likely to present with abnormal bleeding. And we don't really know why. It's probably some kind of genetic factor, maybe some dietary kind of issues. So there was one paper that suggested red meat increases your odds ratio by 1.4. I don't know if that's true, but ultimately we don't really know the reasons why, but we do know that that's an important risk factor. And age, it does increase with age, although once you hit menopause, then usually fibroids shrink because they are hormone dependent, and family history, again, probably related to genetic factors. And I put estrogen there because it does increase the growth of fibroids, but it doesn't cause their generation. That's more of probably genetic things with the other risk factors. And then in terms of location, so they're all within the myometrium, but depending on where they protrude, they're called different things. So if here is the submucosal fibroid, and that's because it protrudes into the innermost layer and then into the uterine cavity. An intramural one is a fibroid that's purely in the muscle layer, but doesn't really protrude out, whereas a subserosal one protrudes on the external surface like this. And then there's a special type called pedunculated fibroids, which have this narrow stalk here, and then they have this the fibroid there. And again, that has important implications for planning treatment. This is something you might see. It's just more of an academic classification system, just describes what degree of extension it is on each surface. But I think it's a bit beyond the scope of the talk, but I thought I'd just include it in case you've seen it before. And as mentioned, half of patients with fibroids don't present and they don't cause any symptoms. But if they do cause clinical symptoms, then they usually present in 3 main ways. And the most common is heavy bleeding, and that's either heavy bleeding on the period or sometimes it can cause bleeding between, but usually it's predominantly a heavy period and sometimes can cause pain as well. The second type of symptoms that it can present is bulk-related symptoms, because you can imagine it's a large mass, and so that exerts pressure on nearby structures, and so they can often present with chronic pain, like chronic pressure type pain, rather than acutely, although fibroids can present acutely as well. And the third main way they could present is with reproductive dysfunctions. So predominantly that's infertility. We'll go on to which types of fibroids in particular cause that. And the other way it can present is with postpartum hemorrhage. So often you don't know that somebody has fibroids. When it comes to the delivery stage, they might have postpartum hemorrhage for an unexplained reason. And sometimes it may just be a fibroid that's causing that. And then mass effect go beyond the symptoms, because if the fibroid is really big, it can compress on the nearby ureter and cause hydronephrosis, or it can compress the bowel nearby, or it can even compress the ovarian vein or the pelvic veins and cause a venous congestion. And then the fibroid itself may undergo degeneration, and that can cause like an acute type pain, or it can also undergo calcification, which is not necessarily a clinical thing, but you might see it on imaging. So often there's lots of like pelvic calcifications, and in particular, like if you're reporting, say, a CTKUB and you're looking for renal or bladder stones, you might see fibroids with stones, and it's just an annoying distractor on trying to find the renal stones. And we mentioned before that estrogen drives the growth of fibroids, and so often they're worsened in pregnancy. And sometimes patients may present for the first time in pregnancy. So they may have had a fibroid all along, but because of the increased estrogen, they present with heavy bleeding during the pregnancy period. And so predominantly heavy bleeding is how they present into healthcare, and that's largely determined by location. So the submucosal ones and the intramural ones tend to bleed a bit more, but the size is a bit like irrelevant. So even very small fibroids can bleed a lot, and sometimes even large ones don't bleed very much. So it's not consistently related to size. Bulk symptoms are usually not the presenting feature, but often if you really take a good history, they may come out in the history that they've had a bit of niggling pain or pressure feeling for a while. So it's present in most patients, but it's not often the reason they present to healthcare. And then of course reproductive complications is the other branch of symptoms that we mentioned. The main reason why it causes it is because it distorts the endometrial cavity, and so implantation is affected. It's usually submucosal fibroids that are implicated most. Intramural a little bit, but the subserosal fibroids, they don't really have much of an effect on the pregnancy rate if you look at the data. And so it's thought to be because of the physical distortion that it causes infertility. And then the other thing to always remember is, always think in the differential, could it be cancer? Predominantly if they're postmenopausal, so any postmenopausal bleeding is cancer until proven otherwise. And certain red flag symptoms that are always worth asking about, say if you're in A&E clerking. So if the history is really, really short and rapid, then that's more in keeping with a malignant growth rather than a benign one, particularly if they're older and postmenopausal. Those are signals that should think about cancer or anything else that makes you think that, this is growing pretty quickly. And you should always consider endometrium as a cause of the bleeding and don't assume that it's a fibroid. So the reason why that's important is someone might have a fibroid and then present with bleeding either, perimenopausally or postmenopausally. You don't assume that it is necessarily due to the fibroid, and always think every time they present, like, could it be something else? Just so you don't miss, another cause of it. Cool. So we'll go on to the main imaging methods for fibroids. So yeah, it is ultrasound, which is the first line, and it's got a very high sensitivity for picking up fibroids. And usually it has to be done TV. So you'd always start with a transabdominal ultrasound because it's a lot less invasive, but you often don't pick up fibroids because the views you get are not as good. And I'll show you a couple of pictures in a second. But actually, usually a patient will have an ultrasound for another reason. Fibroids are incidentally detected, and that always poses a risk, or not a risk, but a dilemma, because you have to think, okay, there's these clinical symptoms, and now I've seen a fibroid on imaging, but is it likely that this imaging finding explains the clinical symptoms? And so that's often the reason why it's tricky, because it's difficult to sometimes characterize exactly where it is. Like, so if someone's presenting with heavy bleeding and you think they've got a subserosal fibroid, now subserosal fibroids are less likely to present with bleeding. So there's always worth thinking in the back of your mind, like, is there something else to explain this clinical symptoms? And on ultrasound, they have a very variable appearance. So usually they appear darker on ultrasound, so it's hypoechoic compared to the normal tissue. But depending on what's happened to the fibroid, it might appear a bit different. So calcium appears different on ultrasound, appears as a shadow, basically. Or if the fibroid is degenerated or has like cystic areas, they can also show up on ultrasound. And the other complicating factor is if it's pedunculated fibroid, it might look like it's near the adnexa and look like an adnexal mass. And so those are a bit of the tricky things on ultrasound. So it's not perfect, but it is the first line imaging method for investigating fibroids. And so I'll talk about ultrasound generally and go through the different types. So either you can have a transabdominal ultrasound or a transvaginal ultrasound. So the abdominal one is where the probe is placed on the patient's lower tummy, and the patient needs a full bladder for the scan because the bladder is used as an acoustic window to transmit the sound and get good pictures. Whereas the transvaginal is more invasive. It's an endocervical probe that is smaller and has higher frequency. And the reason you do that is because you get closer to the structures you want to visualize, and that gets better quality images. So if you look on the left here, it's just a normal transabdominal ultrasound where you try and look at the uterus, and you see the bladder is here and then the uterus is deeper. And I mean, it's okay, but if you look on the right, this is the transvaginal ultrasound, and you can see it's that probe because it's a bit more rounded, and the quality of image that you get is a lot better. And so if you're trying to assess a fibroid on this transabdominal image, then it can be quite difficult unless it's absolutely massive. Whereas the transvaginal ultrasound's a little bit better, and so you can spot smaller fibroids, particularly the ones that are close to the mucosa, like a submucosal fibroid. And so these are just some pictures to show what fibroids look like. So here on the top left, this is all like normal myometrium, and you've got this dark oval shaped thing at the top, which is a small low echogenicity area on the ultrasound, and that's usually a classic appearance of a small fibroid. And again, on the bottom left, you can see another fibroid, but this one is actually a subserosal fibroid because you can see the boundary of the myometrium and it extends beyond that. So again, it's a hypoechoic mass that extends out. And then on the right here, this is a calcified fibroid. And it can be a bit difficult to make out the exact boundaries, but the calcifications go all the way out to the edges. So you can see the calcified bits, which are casting the shadow. And then within that, you've got the fibroid itself. And in this case, it's actually indenting onto the bladder. And so for this patient, they might have some issues with urine frequency and voiding. In terms of other imaging modalities, the one I'd mention is saline infusion ultrasonography. What that is they infuse saline within the uterine cavity and then rescan them. And the reason you do that is to assess how far the fibroid is protruding into the cavity, and it allows better visualization of the submucosal ones, which might be missed on a regular ultrasound, or you might mistake it for an intramural one. And that's important because, as we mentioned, the submucosal ones are more likely to cause fertility problems and are treated differently. So it's important to recognize the submucosal ones are different to the intramural ones. And as you mentioned, that MRI is the best investigation, and it will quantify the size and number of fibroids, although you don't always need it, but it is better to have one before you do any treatment for it. And it really, really helps with the surgical planning. And you can also do it before an embolization because there's some data to suggest that features in MRI are thought to predict outcome, but that's not routinely done everywhere, although I think most places will do an MRI before they do an embolization. And this is a picture just showing the difference that saline infusion does. So on the left here, you can see this hypoechoic area, and it probably is a submucosal fibroid. You can see it kind of indenting on around here, but it's always difficult to tell. You don't know how much it's protruding. But then you infuse saline into the cavity, and on the right, you can see actually this is protruding really, really heavily into the cavity. So it's probably, the reason why, if they presented with infertility, this could be it's a pretty damning reason on why it might be. And then this is just an MRI picture to show what fibroid can look like on MRI. And again, the appearance varies a lot depending on it. But you can see that there's this big circular growth that's different from the uterine myometrium, and it's the most accurate method. You don't always need it, but particularly it's done for treatment planning. And the other benefit of an MRI is it helps identify other causes of the patient's symptoms, particularly for heavy bleeding. Adenomyosis is another common cause, and so it's important to differentiate what's causing the symptoms again for treatment planning. And the other reason why it's worth doing is because it's particularly important for looking at pedunculated fibroids. And the reason for that is if you embolize one of those, there's a higher risk of detachment compared to a regular fibroid. And so if the fibroids detach into the peritoneal cavity, so for like the subserosal ones, there's a higher risk of infection. So you don't want to embolize those if you can help it. So we'll move on to the different treatment options that are available. And so as we mentioned, asymptomatic fibroids, they don't need any treatment or follow-up. You just leave them alone. But if they're symptomatic, then you have to treat it, basically. And the three options are observation to see if it goes away, medical treatments, which have a relatively limited role, but they are good at the first line, and then surgical options. And again, you mentioned location is important because it determines what procedure you do. And so the general approach to treating is you try symptom control first. So you can try various oral contraceptives or other treatments to control bleeding rather than treat the fibroid itself. But if this fails, and often it does, then you would consider doing some kind of intervention. And the main things to know from the patient are if they want children and future plans for fertility, but also do they want to keep the uterus? Because those are two important questions that will help decide what treatment is best for them. So hysterectomy has always been traditionally done for the treatment, and the rationale is very simple. If you don't have a uterus, then you don't have any fibroids, and so it's a very definitive procedure, and it will work pretty much. And especially if the women are a bit older and if they're postmenopausal, you'd consider adding an oophorectomy, to taking the ovaries out, because you would take away the risk for ovarian cancer. But of course, you wouldn't do that on someone premenopausal, because you would then cause premature menopause and then need HRT, which you don't want to do. So that's always another consideration when you're doing a hysterectomy. And this can be done in multiple ways. So an abdominal hysterectomy is through a large incision. A laparoscopic one is laparoscopic, or it can also be done vaginally, depending on how big the uterus is. And so for patients who have definitely completed the family, they say they definitely don't want any more kids, and they're approaching menopause or postmenopausal, then it is the best treatment because it's definitive. But obviously, with any major surgery, there are loads of potential complications. So the surgical risk is an important one to consider. But if they've had previous operations, then again, that makes the procedure difficult and longer. In any case, it's longer, as longer anesthetic time and higher risk of complications. Again, BMI is an important factor as well, because it's another perioperative factor that increases the risk. Generally, it's a much longer hospital admission and stay compared to all of the other treatments. And also for some, there's cultural considerations of wanting to keep the uterus. So in some cultures, it's viewed as kind of losing womanhood, if that makes sense. And so for that group, it's important to consider that and know about the other treatments so you can recommend them if that's what they'd want. So hysteroscopic resection, or TCRF with an acronym, that's the preferred treatment if it's a submucosal fibroid, because it's protruding into the cavity, so that's the best way to approach it to get rid of it. Generally, it's better for smaller lesions. The bigger the lesion is, the more difficult the procedure is. But also, if it's a bigger fibroid, it has a higher risk of bleeding within the procedure, and you might have to abandon. But if it's predominantly if it's just a submucosal fibroid, this is the first line treatment for it, although not all centers will offer it. And then the other option is a myomectomy, which is removal of just the fibroid, but you keep the rest of the myometrium. And again, that can be done laparoscopically or open. But if you want to do it laparoscopically, then the fibroid has to be small enough to take up from the port. And so the largest one is really, really big, or there's absolutely loads of them. You can't do a myomectomy laparoscopically, and it has to be an open operation. And generally, it's an effective procedure. About 80% have symptomatic relief from the operation. What is the largest size fibroid that's been removed laparoscopically? It's actually 21 centimeters, and it weighed 3 kilograms. So that must have been a very difficult operation, and it would not have been fun to assist that one for sure. So normally they wouldn't attempt it if it's 21 centimeters, but yeah, just a bit of trivia in there on myomectomy. Cool. So we'll then move on to embolisation, which is the main interventional treatment for fibroids. I've got two pictures here, just a couple of answers on how each of those might link to fibroid embolisation. The one on the left is a scan of a brain, so it's something to do with neuro. The one on the right is what they used to use for cameras before they had to take pictures on film. Quite hard to just guess randomly. So the first fibroid embolisation was actually done by a neuroradiologist. Don't really know why he was doing fibroid embolisation, but that was done in 1974 in France. And the reason I put the photographic film in, because the material that's used to develop it was the original embolisation material used, the PVA, to do the procedure. So yeah, uterine artery embolisation. So what you're actually embolizing is the blood supply to the uterus. And so it's the actual procedure is uterine artery embolization, but you can do this procedure for other indications, like things that are not fibroids. So they're often used interchangeably, but the actual procedure is embolization of the uterine artery. And the reason for that is that fibroids are very vascular. So in their growth, well, as any tumor grows, it will release vascular growth factors and cause neovascularization, so new blood vessels to form. And so these are very, very vascular that has a rich blood supply. And so the rationale for the embolization is that if you block the blood supply, you then reduce the growth of the fibroid, shrink it down, and then reduce the symptoms of the fibroid. And traditionally, it's been done for patients who are poor surgical candidates or have really high anesthetic risks. So we mentioned before, particularly BMI, but other comorbidities like respiratory disease or cardiac disease. If they've had prior abdominal surgery, that makes the myomectomy a lot more difficult. So every time you go in and do an operation, you have an inflammatory reaction and cause adhesion. So it makes a subsequent one much higher risk, particularly for blood loss and that kind of thing. And so a lot of them may have had either like their appendix out or cesarean sections. And it's important to ask about all of that in the history, because if they had a couple of those, then likelihood is it's the scarring is higher and it's just going to be a lot trickier to do surgically. And so those patients would be suited for an embolization. And also those patients who have a desire for quicker recovery or return to work. So embolization doesn't need a general anesthetic. It's done under local, and usually it's done as a day case or as an inpatient stay for just a day, which is a lot quicker than myomectomy and definitely a lot quicker than a hysterectomy. And so that's another main reason why patients opt for embolization. And the outcome, particularly for bleeding, but also bulk symptoms, is good, and usually 90% of patients experience an improvement in their symptoms. The effect on fertility, however, isn't really known. So traditionally, myomectomy is preferred because we don't know the effects of embolization on fertility, then it's not recommended. Although there's a recent trial, which is the FEM trial, which had a surprising result that the pregnancy rate was higher in the fibroid embolization group, which has caused a bit of a controversy. But I think generally speaking, with the guidelines, if the fertility effect is still relatively unknown. And the other thing to mention is the reintervention rates are a bit higher compared to myomectomy. So within 5 years, myomectomy has a reintervention rate of about 17 to 20%, which is a bit higher in the embolization group, about 25%. So I thought I'd recap a bit of the anatomy. So it's always difficult. Pelvic vascular anatomy is always difficult. And for any of you who've been in the IR rooms at all, if you ever get quizzed on the anatomy, it's it's often a bit tricky. I know this meme is about prostate embolization, but kind of applies for the uterine artery as well. So essentially, the abdominal aorta branches into the common iliacs on the left and right at the level of L4. And then the common iliac splits again into the external iliac, and that becomes the femoral artery, and the internal iliac. And then that splits into the anterior and posterior division. So the uterine artery is a branch of the anterior division of the internal iliac artery. And so here on the right, if you look at the angiogram, this is the internal iliac artery. And the uterine artery is this one that's going towards the midline and then kind of very squiggly. And it usually has this tortuous course as opposed to some of the other vessels that are a little bit straighter. And the Seldinger technique is an important concept to cover as well. It's kind of the principle of all or most of the IR procedures that we do. And so the principle of that is if you get a guide wire somewhere, then you can do anything pretty much. So particularly for vessels, how that's applied is that the ultrasound probe is used to you look at the vessel, and the initial access is done with just a needle. And once needle access is gained, you then pass a wire through that needle, remove the needle, so you've got your guide wire access, and then you put a sheath over this guide wire. And so the sheath is basically like a fancy cannula, but it's got a hemostatic valve at the end of it so that you can pass instruments through, but then blood doesn't come back. And it just secures your vascular access so that you can kind of do what you need to do for the procedure. And so got some pictures on how ultrasound access is gained. So the first step is you get a view of the artery in long, and the importance of selecting the right site is important. So if you want to access the femoral artery, you should go ideally above the bifurcation. You don't want to hit an area that's calcified, but then also you want to aim where it's right in front of the bone, because if there is a problem, you need to be able to compress the artery against the bone, because like manual compression is usually the treatment if there's, bleeding and stuff. So in terms of the right area, that's where you're aiming. And then once you've got this view, you can then get your needle access. So you'd infiltrate with local first, all the way down to the vessel wall, and then you use the needle with a 45-degree angle under ultrasound guidance in order to gain access. And then once you have access, and that can be either radial or femoral. So this is a picture of radial access. So I thought I'd show you this. The radial artery is cannulated, and then a specific thing for radial artery is you use a radial cocktail, which is a mix of a few drugs in order to prevent spasm. So there's a calcium channel blocker and a couple of other drugs which I never remember the doses of, but that's given to make sure that you reduce spasm, because it's a smaller artery than the femoral one. And once you have your access and your sheath in, you then navigate a catheter down to the aorta, into the internal iliacs, and then into the uterine artery and do the procedure. So as you mentioned, traditionally it's done femorally. It's a bit closer to the uterine artery, but generally there's been a move towards doing radial access because patients prefer it and the complication rate is a bit lower compared to femoral access. So you might be able to do it as a day case if you do radially. And also the benefit of radial access is the patients can get up early, whereas if they've got femoral access, they have to lie down for a bit of time, because otherwise then it risks access site problems. And so as I mentioned, you navigate the guide wire all the way to the uterine artery, catheter over it, and once you're there, you embolize it with these particles until stasis, so until the blood flow stops. And usually it's done bilaterally, so you do both uterine arteries at the same time. In terms of embolization, so actually we're not 100% sure how it works, but this diagram kind of explains how we think it works. So these are the embolic spheres, or the particles that are used, and they're injected through the catheter. And when they come out of the catheter, they just aggregate within the vessel. And the effect of this is that it slows down blood flow. And I don't know if you all remember from preclinical med school, this is Burkhoff's triad. And when blood flow slows, it clots more easily, and that kind of fills in the gaps. But also, it causes an inflammatory reaction and then fibrosis the vessel, which occludes it. And that's kind of how we think embolization works. So this is just some images to show pre and post embolization. So on the left here, we've got on the right side of the picture, we've got this hypervascular fibroid. So these vessels are the uterine artery, and these smaller vessels are this hypervascular area. So then embolic material was injected, and then on the right picture, you can see those hypervascular areas are gone. And so this is a successful embolization of the uterine artery on this side. And so this patient would have a bilateral embolization for the procedure. After the procedure, I think pain control is the main issue to get on top of, and it's the main reason why patients require an overnight admission. So once you do the embolization, if it necroses, that process can cause a lot of pain. Bigger fibroids tend to cause more pain, and it doesn't start immediately after the procedure. Usually it starts a couple of hours after, and it peaks around 12 hours, which is why they need an overnight stay. But it is self-limited, and it's treated often with a PCA, but it's important to be proactive with it. So say if you're looking after these patients on the ward, should write them up for loads and loads of pain relief and be very liberal with it, and be proactive with it, because otherwise they might be stuck in the middle of the night waiting a while for pain relief. So if you do it proactively, then that just helps you get on top of the pain control. There's lots of other different techniques that are used by various people. So intra-arterial lidocaine is something that's been trialed, dexamethasone as well, and then hypogastric nerve block is one of these newer things that I don't know too much about. But for those of you, if you've seen cases on Twitter, there's been a few where they're like, oh, we've done a nerve block, and they were out by 3 hours after the case or something like that. It's not routinely done, but I just thought I'd mention that it exists, and it's a technique for improving pain control, because I think that's the main issue that we need to get on top of after the case. Some patients undergo what's called post-embolization syndrome. It's kind of an inflammatory reaction, bit of fever and malaise, but that's self-limiting with NSAIDs and goes away after a few days. And the other one, particularly with pedunculated fibroids, is expulsion. So like the fibroid can detach from the stalk, and that's fine unless it gets stuck. in which case often these patients can present with pain into the emergency department. So it's worth noting that that's an early complication of embolization. And some patients get discharge after the procedure, but again, that's usually self-limiting. It always might indicate infection, which is a complication of any procedure. So that's another complication that can happen sometimes. And then follow-up imaging. So on the left here, it's a fibroid on an MRI. And when it gets infarcted, it gets darker and then shrinks over time. So on the left, it's a bit bigger, and then after embolization, it's infarcted and smaller. And so this is less likely to cause symptoms after the embolization. So that summarize the main features. So both embolization and myomectomy are used for intramural and subserosal fibroids, but the procedure is done differently. So it's radial femoral access for embolization. Myomectomy is done either laparoscopically or open surgery. Typically, the stay is a lot shorter for the embolization because they don't need a general anesthetic and there's a lot less tissue trauma. So the recovery period's a bit quicker. Although, as I mentioned before, the reintervention rate is a little bit higher. And these are some of the complications that we've talked about. So yeah, in summary, in terms of treating fibroids, we always try a symptom control first, either with NSAIDs or oral contraceptives, or tranexamic acid is often used for bleeding. But the treatment options depend on where the fibroid is. So submucosal, you try for a hysteroscopy intervention first. If it's intramural or subserosal, then you choose between a myomectomy or an embolization. If it's a higher risk for surgery, then embolization is preferred. Whereas if fertility is desired, then myomectomy is preferred because of the unclear long-term effects of fertility on embolization. And then hysterectomy is usually done nowadays as a last resort, particularly for like CCG funding issues and that kind of thing. We haven't really talked much about medical treatment because it has a very limited role. So one medical treatment they use is GnRH, which is a hormone, or Zoladex, as you might know it. And so that is basically a hormonal treatment to shrink the size of the fibroids. And it does work, but there's lots of side effects of being on long-term hormonal treatments. But sometimes they use it just for a few months before a myomectomy to shrink the size of the fibroid and make the operation easier. But as a primary treatment, it doesn't really have much of a role in the management of fibroids. So as I mentioned, uterine artery embolization is not, the technique is not just used for fibroids, but it's also used to treat postpartum hemorrhage. So here I've just taken a screenshot of the Royal College of Obs and Gynae's Green Top guidelines, which often come up in exams. And this is a section on embolization. And so it is an effective treatment for postpartum hemorrhage. So if medical treatment hasn't worked, then your next options are either uterine artery ligation, balloon tamponade, or embolization. And it's an effective technique, but often the limiting factor is logistics. You know, if something as simple as how far is the IR person from the maternity, because if it's like 15 minutes away, it's actually probably impractical to do an embolization. So that often all depends on local factors and availability of C-arms and that kind of thing. But it is an effective way to control bleeding, and it saves a hysterectomy usually. And so it is used as an emergency treatment as well as in the elective setting for fibroids. And the last thing I wanted to mention on embolization in particular was the role of global health and UAE. So particularly in Africa, as you mentioned, that black race is the most consistent risk factor of fibroids. And so the burden is very high, as well as the cultural issues with keeping the uterus. And PPH mortality is also very high. And part of the reason for that, obviously, is generally poor healthcare facilities, but the surgical risk is quite high. So any operation is high risk. And so embolization plays a role in both of these conditions. But the main trouble is A, the lack of skilled operators, and then B, the fact that a lot of these embolic materials and catheters are very, very expensive. But there are some cheaper alternatives being investigated. So here's a vial of something called Fair Embo, which is basically cut up sutures suspended in a solution, and that is used as an embolic material to like close off the vessel. And it's shown to be as effective or almost as effective as the particles, but for a fraction of a price, because some of the vials of these embolic particles cost like 100, 200 quid, whereas a vial of this is much cheaper. And so there are these, alternatives being investigated. So it's not all about like super fancy equipment and stuff. Sometimes the simple solutions are the most effective ones. And so this is kind of another area for future exploration. And I've just got a couple more slides talking about the role of interventional radiology in other conditions. So the first one I want to mention is pelvic congestion syndrome and the role of embolization. So with this, I mean, a lot of patients have chronic pelvic pain, and that's defined as non-cyclical pain for at least 3 months. Some definitions say 6. And it's a very common condition with a high prevalence, and it forms a high percentage of gynae referrals, but with a very wide differential diagnosis. And so one of these causes is pelvic congestion syndrome, and one of the key features of it is pain that's worse on standing, because what happens is the veins, they reflux, and so when you stand up, then the gravity pulls the blood there, and you get more of a pain or discomfort as such. But then there are obviously other causes of chronic pain that were kind of beyond the scope of this talk. And so ovarian vein embolization is often used as a treatment for that. But the tricky thing is it's a lot of people do have dilated veins, and so again, it's a similar problem to fibroids in you see an imaging finding, but then how does that relate to the symptoms? And so that's something that's quite specialist. But I thought I'd mention ovarian vein embolization because it is something it's sometimes used as a treatment for pelvic congestion syndrome. And then the other thing is fallopian tube recanalization. So infertility is a multifactorial problem, and in cases where there's a fallopian tube blockage, so most commonly because of previous pelvic inflammatory disease, often it's like a physical closure of the fallopian tube that's causing the infertility. So one thing you can do is recanalize the fallopian tube. So the top left image here is what we call a HSG, or a hysterosalpingogram, which is kind of a live X-ray with dye inserted into in the cavity, and that shows there's a blockage of this fallopian tube. So on the patient's right, or the left of your screen, this kind of wispy bit is the lumen of the fallopian tube, but on the other side you can't see it because it's completely blocked off. And so what happens is they pass a guide wire and dilate up, and you can see on the post-treatment images that there is now opened. And so that's called a fallopian tube recanalization, particularly done for more proximal blocks, whereas if the block is really, really far, then it's a bit tricky to get there. So that's just another way in which IR can be used for some other conditions. And I've just included these further reading links if you wanted to, particularly for the medical students in the audience. Read the guidelines because they're often tested in finals exams on the management of particularly PPH, but also fibroids as well. And cool, and that's it.